I'm excited for today's show because we have our very first guest, and the topic we're going to tackle today is a subject that doesn't really get much attention: women of color and infertility.
Whoever thought making a baby could be so hard? Luckily, the fertility journey isn't meant to be traveled alone. Eloise Drain has helped hundreds of people build and grow their families over the last 15 years, and she's ready to share her insider knowledge and expertise with you. So grab a seat and let's talk fertility and alternative family building in the Fertility Café.
Welcome to Fertility Café. I'm Eloise Drain. I'm excited for today's show because we have our very first guest, and the topic we're going to tackle today is a subject that doesn't really get much attention: women of color and infertility. Stereotypes in the media and the lack of conversation surrounding Black women and infertility suggest that women of color are completely capable and able to have children whenever they're ready. Even stemming all the way back to slavery, young Black women were presumed to be extremely fertile by slave owners. However, we've learned that this is far from the truth. In fact, studies suggest that 12% of all women up to age 44 suffer from infertility, with women of color being twice as likely to experience infertility. Oddly, only 8% of them seek medical attention to treat infertility, in comparison to about 15% of white women that seek treatment. This information brings into question, why are women of color not seeking treatment, and why is there so little conversation about infertility in the community? Today, we'll explore a number of explanations that help to explain the stigma surrounding infertility and how we can bring this topic to the forefront for women of color. Now, let me share a bit about my guest. Dr. Monica Best completed her fellowship in reproductive endocrinology and infertility at the Emory University School of Medicine. She's currently a practicing reproductive endocrinologist and infertility specialist at Reproductive Biology Associates in Atlanta. She has personally experienced infertility and understands firsthand the physical and psychological challenges faced by couples with infertility. Her passion is helping couples through all aspects of their unique infertility journey. It gives her sheer joy to share in the excitement couples experience as they build the family of their dreams. Thank you for joining us on the Fertility Café today, Dr. Best.
Thank you so much for having me.
Yes.
I appreciate having the time to sit down and talk about some important issues.
Yes, these are very important issues. And you're one of the top reproductive endocrinologists in Atlanta, and you're also African-American woman, which gives you a very unique perspective on our topic today. For more than 15 years, I've witnessed and experienced the lack of communication surrounding infertility in the Black community. And it's astounding that in the year 2020, we still have staggering statistics that show women of color aren't seeking the treatment that they need for infertility. So my first question to you is, why do you feel women of color are 2 times more likely to experience infertility as white women, but seek medical help for half as much?
Yeah, so, this is obviously, being a woman of color who has struggled with infertility, it saddens me that people aren't aware of the issues surrounding infertility and don't seek care. The surveys seem to suggest that African American women in particular are about 50% less likely than women from other ethnic backgrounds to actually feel comfortable broaching the topic of infertility with their care providers. So, it really is sad that, we really struggle in complete silence and don't actually feel comfortable even broaching the topic. If we don't bring something up, if we don't address a problem, then, no one knows how to fix it for us. We tend to be very spiritual people, as African Americans, as am I. But I think infertility should really be viewed just like any other medical problem.
Mm-hmm.
We have, I think, God in our lives, and we hear people like our moms and our grandmothers telling us, "Baby, just pray about it. If it was meant to be, it would be."
Mm-hmm.
And, just like any other healthcare problem like diabetes or high blood pressure, we have to talk about it. We have to tackle it like we do any other health problem, and actually do something about it, in these cases. So,
Do you think another reason too is that from, when we were young, we were taught, girl, you better not get pregnant. You better not, you better go to school. You better get your education. Pregnancy is the last thing that you should have on your mind. And it wasn't even a topic of discussion. Not, at least not in my household.
Not in my house either. I mean, my parents told me, to get my education, and then there was this open-ended, oh, well, everything else will come. And, given what I know about reproduction and infertility now, that was really just sort of the worst advice. I mean, we're born with all the eggs we're ever going to have, and over time there's some decline in that number. And no matter how successful I am, or however much education I get, still I have to contend with ovarian physiology. So my parents were very guarded about information as it relates to reproduction, and I think it really hurts us to not have open discussions about how to plan our families, how to contracept when we are not ready to have children, but still be mindful of how ovarian physiology works, and how if we are delaying childbearing, we need to be still thinking about our fertility, and if it's something that we want to be able to accomplish at a later time in our life, maybe thinking about fertility preservation, and other ways to be able to guard one's ability to have the family that they want one day.
Yes, absolutely. And I think the other factor, for everybody, it doesn't matter what race you are, is cost.
Absolutely.
Which is a huge factor, especially in so many of the states where fertility care is not even something that is paid for through insurance. And a lot of people are paying all of this out of pocket. So I think cost is going to be a big factor probably for everybody across the board. Not probably, it is a factor for everybody across the board.
Yeah, it absolutely is, a factor, for sure. I mean, and, I think women of all ethnic backgrounds are delaying childbearing, and, pursuing other things that sort of compete with this. So it's definitely an issue that's on everyone's mind, regardless of what your ethnic background is.
Sure, absolutely. So are there specific fertility and reproductive issues that are more prevalent among women of color than other women?
Yes, I mean, one of the biggest health and sort of reproductive issues that Black women struggle with is going to be uterine fibroids. Uterine fibroids are present in about 60% of Caucasian women. So these are common reproductive issues that all women deal with, but African American women have a higher rate of having uterine fibroids, and it's probably about 80%. The question is, where are these fibroids located? Are they located in the area of the uterus where they may impact implantation? Are they big enough to push on or distort the reproductive anatomy, like distorting or kinking or blocking the fallopian tubes? Oftentimes, even when we do surgery to remove fibroids, they can leave behind scar tissue that blocks the tubes or scars the tubes. This scar tissue may be left behind inside of the uterine cavity that may be an impediment to implantation. So certainly African American women are more likely to have fibroids. They're probably more likely also to have clinically significant uterine fibroids that may impact pregnancy and fertility. Other reproductive problems that may be more common in African American women and men is, basically obesity and other medical problems that stem from obesity and that may negatively impact fertility. Obviously, the obesity epidemic is something that people of all ethnic backgrounds are struggling with, but if you look at the statistics, we may be more likely to struggle with this. So you can have ovulatory disorders that stem from, obesity. Again, other medical problems that are going to impact fertility and pregnancy in women. And then we know in men, obesity can affect, basically the viability of sperm, motility of sperm. So those are things that we need to think about.
Are there signs? So if somebody had fibroids, obviously they need to really go to the doctors. But from someone who's younger or who has really no idea, is there any indication to someone to let them know, well, something's going on? Maybe it's fibroid or maybe it's something else, but there's something going on and I need to maybe I need to go and look for someone or seek someone out. Like, what are the signs it's time to come in and see you? And when someone comes in with issues, what can they expect?
So I think that's a really important question to ask. Just because, understanding if there's a problem, the earlier the better. Just kind of going back to what I talked about in terms of ovarian reserve and us having a limited supply and quality of eggs, so really understanding when there's a problem, when to seek care so that you understand what the challenges are is so important. So, if you're under 35 years of age and you've been either attempting pregnancy for a year, or, again, it's important to read between the lines. You've been having unprotected intercourse and have not been using any contraception for a year and have not conceived. It is a good time for you to come in and undergo an infertility evaluation. If you are over 35, again, going back to that limited supply of eggs and also quality of eggs as we get older, in addition to the fact that you're more likely to have other reproductive problems crop up over time, we give you 6 months to either attempt to conceive without conceiving or have unprotected intercourse without conceiving before we say, look, you really need to come in and seek some answers as to why you're not getting pregnant. If you also are someone who, who is, has issues with ovulation, you don't have regular cycles, you may be someone who may want to come in a little sooner because how can you attempt pregnancy if you're not ovulating? Mm-hmm. So just to, kind of bang your head against the wall and only have 2 cycles a year, that doesn't make sense either. So, if you've got ovulatory dysfunction or you've got irregular menstrual cycles, or, if you know that your partner has an issue with sperm, again, those are reasons to seek care maybe perhaps a little sooner so that we can identify the challenges and get around them and get pregnant.
I mean, I know as women, we're used to being poked and prodded at the doctor's office. And Lord, don't get me started on the medieval torture device y'all call the speculum.
Exactly.
But I'd imagine there are multiple steps involved in diagnosing infertility. And it's more than just an exam or blood work. Can you just walk us through the stages of diagnosis of infertility?
Absolutely. So I kind of try to make things as simple as I can, when patients come in for the evaluation, just so they understand, okay, what elements of this evaluation do I most care about, and why do I care? So, the first thing is eggs. So one of the most important things is, okay, what is the number of eggs that this patient has in her personal egg bank still remaining? and what is the quality of those eggs. And basically, the number of eggs we evaluate primarily in two different ways. One is we can actually do an ultrasound of the ovaries to count the number of resting eggs on the ovary, and that is a patient's antral follicle count. A normal number in a normal reproductive age woman is somewhere between 10 to 20 of those eggs that I can count on the ovaries at any given time in any given month. The other one is called the AMH, or anti-Müllerian hormone level. And this hormone is actually secreted from the cells that support resting eggs in the ovary. And the higher that number is, the better. And it gives me some idea of the number of eggs still remaining. So I kind of pair that with that antral follicle count. Your age is going to dictate what the quality of those eggs is. So it's going to give me a prediction in terms of what your miscarriage risk is with each pregnancy. And so that's kind of a measure of the quality of eggs. The second thing is going to be a semen analysis for the partner. Again, if it's a same-sex couple, again, there's different guidelines for that, but still we're going to want to know the same things. For example, if it's a same-sex female couple, I'm going to want to know about the eggs. If we're using donor sperm, then that's going to be fairly standard. But there's some other information we want to know about the partner who's going to be getting pregnant. So, of course, if it's a heterosexual couple, the semen analysis is going to be important. Third, if, again, a couple with infertility comes in, I'm going to want to know, are the tubes open? And so usually we evaluate that with an HSG, or hysterosalpingogram, where we put dye into the uterus and we look at that dye and whether or not it spills out of the tubes under X-ray guidance. And so that's the gold standard for evaluating the tubes. And so I'm going to want to get that information. And then the fourth thing is a careful uterine cavity evaluation. So again, because I tend to be able to pick up in my infertile population more polyps, which are abnormal growths of tissue lining the endometrium of the uterus, or fibroids, I want to get a good evaluation of the uterine cavity. And so what we do is we instill salt water inside of the cavity to bring the walls of the uterus apart so that we can scan through by ultrasound and be able to evaluate the inside of the uterine cavity where implantation occurs, to make sure we don't have any pathology like polyps or fibroids that may interfere.
So, and I know we can go from pretty much like one extreme to the next, but if you give 100 women, walked into your exam and you just did this diagnosis of infertility, can you break down maybe the percentages of how many would actually need minimal treatment to intermediate treatment to then full-on third-party assistance?
Yeah, so, it's a little bit more complicated just because it really depends on what factors are at play in terms of the couple's infertility. If this is again, a heterosexual couple, the age of the female is very important, as patients above age 40 are more likely to have some diminished ovarian reserve, and may need more aggressive therapy like IVF or even egg donation to make getting pregnant more efficient and miscarriage risk lower. If there is a severe male factor, for example, which happens 30% of the time, then IVF might be recommended, since the odds of a couple being able to spontaneously conceive or to get pregnant with less aggressive treatment like intrauterine inseminations, that their odds of success with that are going to be severely diminished. So, you don't want to have a patient paying emotional or financial resources for something that's going to be less likely to work. If you fall in the 10% of reproductive age women who have PCOS, and you're less than 35 and you just have a problem making a mature egg each month or ovulating, patients in this population may be more likely to get away with less aggressive treatment, like, helping them make an egg with oral medications and then inseminations. So, it's also important to remember, kind of social, societal factors that are leading women to start their families later, and again, may need more aggressive therapy like IVF to preserve their fertility, like either by preserving embryos with IVF so that they can have the family sizes that they want to have. They're getting started later in life. Again, I'm going to be talking globally. Okay, what are your family goals here? And, even if they could have done less aggressive therapy, again, the worry is by the time they get back to have their next baby, because they've always wanted to have 2 children, again, age may be more of a factor, treatment may be less efficient. So sometimes those patients will opt for more aggressive therapy so that they're able to freeze eggs or embryos for future children.
And I think too, one of our issues is that we all, Dr. Google, go on Dr. Google. And Dr. Google could scare even the most confident of women into thinking the worst thing. You can go on there with a headache and some back pain, and the next thing you know, you dying of cancer. So it definitely is a big thing, is to just, instead of trying to figure it out on your own, is to actually schedule that appointment and go be seen. So I'm curious, because we've been talking about the female infertility, but what about male factor infertility, and how prevalent is infertility among men in the Black community? And do you see hesitation from, specifically Black men, getting them into even, be willing to see a doctor?
Yes. So, it's important to remember, as much as I talk about, women and their ovarian reserve and being sort of this champion of increasing our awareness, it's important to remember that, 30% of men are going to be infertile. And just sort of remembering some of those same dynamics that we see with African American women seeking care less than 50% of the time, or not even feeling comfortable enough to discuss these issues, less than 50% of the time, as compared to their women of other ethnic groups. So that has to impact the ability of Black men to present for evaluation and treatment, because their partners don't even talk about it, So, so I think that, although we don't have good data to support it, I think that one can surmise that, if African American women are seeking care, basically, 50% less than their counterparts of other ethnic groups, then Black men are also being left out as well.
Yeah.
Okay, because it's not being brought to the attention of the provider, and therefore care cannot be provided. So, I think it's important to, again, raise awareness, to not have this sense of shame, as though there's something wrong with us. Because I think that is also a deterrent. It's like, what's wrong with me, and, it's important to understand that you're not the only one struggling. Everybody, 1 in 8 people struggle with infertility. And again, as we get older, above 38 years old, it's 1 in 4, so, you are not alone, and just understanding that it's okay to ask for help. As a matter of fact, it's going to benefit you to ask for help as soon as there's an issue.
Well, I think the other problem is, there's this stigma that you're not supposed to put your business out there, and you can't really share this information with people. And then it's bad enough that, there's family members or friends who just are completely oblivious to what's going on. And so every 5 minutes they're asking you, okay, when you've been married for all these years, or when are you going to have a baby? And what why y'all waiting? And I think the other issue is that from when we are young, it's not, no one talks to you about your reproductive health. No one is talking to you about, when you do get your, as a female, when you do get your menstrual cycle, and how that should be and what it should look like. And if you started your cycle at 12 and you were getting it every single month, and then at 15, it completely goes away and you don't see it again, and you haven't been sexually active, that,
Right.
there's no underlying cause of like, well, I didn't really do anything. I mean, why would, and it's just like, well, I don't want to go and tell anybody. Well, I'm sure it'll come back, and it's just like, no.
Yeah. Yeah. No. And again, I think that's why, it's really up to us to raise awareness and, speak up, speak out, make sure that we're educating, young women and girls about their reproductive health and presenting options, and an understanding of their body and their physiology, and hopefully, doing the same with men as well. Again, you think about the causes of infertility, 30% are female, 30% are male, 40% both. So when people have these aspirations of having a family and no one has taken the time to talk to them about their reproductive health, it's really sad when later on we realized that there was a window where we could have acted, and we just didn't know. And so I think that's what is so great about what you're doing is raising awareness so that that no one can say, well, I didn't know, or I didn't know that there are resources for me. It's important for people not to feel alone or marginalized, and I think that's we oftentimes as women and men of color, we sort of internalize that, and we don't seek the help that we need. And so I think that's why what you're doing is so important, in terms of educating people about their reproductive health, and trying to preserve our rights to have families when we're ready for them.
Sure. Absolutely. I mean, and if you think about it too, just society now in general, there's more and more people actually now having infertility issues than I think have ever before.
Absolutely. I mean, because basically the women having their children above age 35 has gone up like 900% since 1970. So, think about, we've got an accelerated loss of eggs starting at age 30, and then that increases exponentially after age 35. So also we see quality of eggs going down at that point as well. And so, most people are, just finishing with whatever their education is, and they're getting into their careers. If you think about, African American women, we are the fastest growing group of entrepreneurs in America. The statistics show it, they bear it out. And I think, again, we are pursuing those things sometimes at the expense of thinking about our physiology. I mean, I know we see celebrities having children in their late 40s and 50s, but the reality is that much of this is through egg donation, which again is always an option. But, I'm about women understanding all of their options
Absolutely.
as early as possible so that they can make the best decision for them.
And now there's a new term called trimester zero, which refers to the preconception timeframe where women should start preparing for a future pregnancy and focus on preserving their fertility options. How how can young women preserve their fertility, and when should they start, and what steps should they take to do that, and how early do you think someone should actually begin?
Yeah, so, I mean, I think that there's like a considerable amount of sort of a differing an opinion around this. I obviously don't want to create like a fear or panic. I think, if we look at kind of what happens starting in the 30s, into the in the early 30s into the mid 30s in terms of decline in ovarian reserve. I would just say that, I think it makes sense in the early 30s, late 20s, early 30s to have a sense of what your ovarian reserve is, particularly if you have educational goals or career goals that are going to push your family building, into your 30s. Just to kind of get a sense of that, or if you don't have a partner yet. So, the assessment of your ovarian reserve can easily be done without having to go in for formal egg count, like I was talking about before, by just getting your AMH or anti-Mullerian hormone level drawn. And I would say let's do that in our late 20s. Or if we notice that our cycles are becoming irregular, even in our 20s. I diagnose you know, um, you know, premature ovarian failure. The new term is primary ovarian insufficiency, sometimes in women in their teens and 20s. Now, arguably, it may be, by the time that's diagnosed, it's oftentimes not efficient to freeze eggs. But the point is to just have an awareness of your body. What is going on? Should I just go get my ovarian reserve checked, or should I talk to my provider about what's going on with me, and will this impact my ability to have a family? So checking your AMH, I say late 20s, early 30s, particularly if you don't have a partner, you're not ready for your childbearing yet, because you may want to take that window and preserve eggs for the future. And so the younger you are, again, the more eggs you're going to have, the more efficient the process is, because you will also have better quality eggs. So if you think about what the miscarriage risk or the likelihood of having releasing genetically abnormal eggs, at different age points, the younger you are, the least amount of time those eggs have been around, and the lower your odds of releasing a chromosomally abnormal egg, and that chromosomally abnormal egg leading to an embryo that's abnormal and you having a miscarriage. So at age 25, probably the risk of miscarriage is probably somewhere around 10-15%. By age 42, that risk is probably 65%. So again, the younger you are, at the time that you freeze eggs, the more eggs you're going to have, the better the quality of those eggs. So, I think, doing some assessment in your late 20s, if you aren't ready yet, makes a whole lot of sense.
Yep.
And doing that AMH makes sense to give you knowledge of what's going on. So if you do decide to preserve fertility, you're doing it at a time where you can be most efficient.
Sure. And you talked about the miscarriage, and the older you get, the higher there could be an issue. Can you talk about if someone needed to utilize a gestational carrier, and the quality of the embryos, and compared to, if you had a gestational carrier who was 38 years old using donor eggs, and how that would look compared to a woman who's using her own genetic material and carrying the pregnancy, and what the difference is there?
Yeah, absolutely. So I think one of the things that's most astounding to people is the uterus really doesn't age in the same way that eggs do. Okay, so we have, for example, we have one of the largest donor egg programs in the country, and believe it or not, women up to age 55, as long as they're healthy and they complete certain medical evaluation for clearance, they can conceive up to age 55 with donor egg, with me creating embryos from an egg donor who's less than 30 and potentially their husband's sperm, doing a transfer of those embryos from younger eggs even into a woman who's 50 is going to yield the same pregnancy rate and miscarriage risk as is tied to the age of the egg donor. Okay, so the uterus doesn't predict pregnancy rates and miscarriage. It's actually the egg, and the age of the egg is gonna dictate our success. So really, the uterus in a surrogate who's 38, if the eggs are 25, then that surrogate is going to have a 25-year-old's pregnancy rate and miscarriage risk. So, so those things are conserved regardless of the uterus. Again, assuming the uterine cavity is normal, we don't have fibroids or polyps. Again, those are things that would be evaluated.
And what about sperm? Does that have a factor in how old the man is when it comes to creating the embryo?
Not in the same way that we think about in terms of the age of the egg impacting miscarriage risk and pregnancy rate. The reason why is because men generate fresh sperm from stem cells every 3 months of their life. So the oldest sperm is 3 months. So men don't contribute at all to embryo quality in the same way we think about eggs, because our eggs have been around our entire life. There's an increased risk as we get older of those eggs being genetically injured, and when they're fertilized, giving rise to genetically abnormal embryos. The same risk doesn't exist for men in terms of contributing to embryo quality. So really, it all gets tied into the age of the egg, and that is what predicts pregnancy rates. The younger the egg, the better the pregnancy rate, and the lower the miscarriage risk.
So can you talk a little bit about, as women, how the eggs are produced? So,
yes,
we're born with however many, and they die off and so forth.
Yes. So that's kind of the depressing thing about being a female. We have millions of eggs while we're in utero. And then, by the time we know that we lose eggs as we get older, to the point where by the time we reach puberty, we have probably about 500,000 eggs. And then over the course of our reproductive life, say from the age of 12 until the average age of menopause, which is 42, we're going to ovulate about 500 eggs in our entire life. And so, again, as we age, we see this accelerated loss of eggs around age 35 to 40. But what's happening also is, again, those eggs have been around our entire lives. And so there's some increased risk of chromosomal or genetic injury to those eggs as we get older. That leads to, again, not only an increased rate of miscarriage, but because we have fewer eggs, it's harder to get pregnant, and it's harder to stay pregnant because of the miscarriage risk.
So then what about those women? As you mentioned, you guys have a big donor bank. And for women who are interested in becoming egg donors, how can they be guaranteed that they would have enough eggs for when they decide that they want to have their own children?
Yeah, so that's really a good question. When you think about how how a mature egg is produced each month. Again, like I mentioned before, if I were to scan the ovaries, I would see about 10 to 20 resting eggs on the ovary at any given month. Again, you've got thousands of eggs in your personal egg bank, but generally the ones that I can see are the ones that have receptors for what's called FSH, which stimulates the maturation of your eggs over the course of the month. Okay, and so what's going to happen is the brain is going to release FSH, which stimulates usually about 10 to 20 eggs to start to grow in any given month. And then usually by kind of the middle of your cycle, you're going to get an LH surge, which is going to help you ovulate your one mature egg out of those 10 to 20 that were growing at the beginning of the month. And so you're going to release that one egg, and then what's going to happen is those other 9 to 19 are going to die, okay? So they didn't vie well enough to become your one dominant follicle out of those 10 to 20, so they're going to die. If that egg that gets ovulated and hopefully gets picked up by the fallopian tube doesn't end up getting fertilized there, that egg is going to die. So ultimately, what we're doing with IVF is we're giving medications to overwhelm the system so we no longer have competition among those 10 to 20 eggs, and we can stimulate the growth of all 10 of those follicles and rescue them. Okay, because remember, they would have died in your natural cycle, right? And so by giving more FSH, like we do with IVF, we're rescuing the remainder of those follicles. And so what we're doing is we're maturing, instead of having one mature egg like in your natural cycle, we're giving injectable medications to hopefully yield 10 to 20 mature eggs. Again, only mature eggs can be fertilized. So we don't have a net loss of eggs in donors that come through that donate their eggs. All we're doing is rescuing what would have died that month. So there isn't a net reduction in someone's eggs when they come and donate their eggs, if they're a donor. Okay. So, I think it's just important for those donors, just like all women, to be mindful of their ovarian reserve and be thinking about when do they want to start their family and preserving their ability to be able to do that efficiently by understanding what's going on with their ovarian reserve. By default, women who are donors are going to have excellent ovarian reserve, but they're also going to be less than 30 years of age, right? So, most of us are going to have a good number of eggs and a good quality of eggs at that point. But, donors may run into problems just like the rest of us do by waiting too long to start their family. And then overall, their number of eggs is going to decline. But the act of donating your eggs does not reduce your net number of eggs that you'll have for later. That number is going to be the same and decline as it would with age, just like everyone else. So what we've done in our donor program is, we have designed it in such a way, if you are, a good donor and you've done, 3 cycles of egg donation, on that third cycle, we will allow you to preserve some of those eggs, and we will cover the cost of freezing those eggs for you for later. So which I think is great. But again, it's not because the process is going to decrease your net number of eggs that you will have for yourself later, but I think it's a good idea, and it's really a good service to offer our donors who are doing something good for someone that ultimately will get pregnant with their eggs.
Right. So, Dr. Best, I know we have talked for quite some bit, and I know we could probably go on and on this because there's a whole lot of other questions that keep popping in my head, and I'm like, no, let me just stop here. But is there any
we could talk forever.
I know. But is there any final points that you wanted to kind of share that you think that would be beneficial for, the listeners to know?
Yeah, I mean, I think probably, my like I said before in this discussion, I feel like I am the champion for, increasing awareness and education to young women. Being a physician who also struggled with infertility myself, I am so grateful to have had the knowledge to check my AMH. Of course, when I evaluated my AMH, it was low, and it allowed me to be able to act. And so, I was able to do IVF and conceive my daughter, and also able to do fertility preservation by being able to freeze eggs and embryos for later, so that I had the option to have another child in the future more efficiently, knowing that I had started so late in the game because I had to go to college and then med school and then residency and then fellowship before I was ready, So, I was already starting in my mid-30s, and I'm just grateful for the knowledge, and I think that is what I feel like is most important for us to educate and empower and impart this knowledge to women so that they understand and they can assess their ovarian reserve and understand what options they have and be more efficient at building the families that they want to have for themselves, because, everybody wants it all. But we have to learn how to, as they say, walk and chew gum together, focus on what our career and educational aspirations are, and still be thinking about how do we guard our ovarian reserve. People are building, blended families, and, potentially, remarrying and wanting to start families anew, and, just having the ability to preserve fertility really leaves options for women that didn't exist before. Men can go restart and build and have other families, but women can't, So I think up until this point, before we had the ability to preserve fertility, I think, women didn't have as many options as they have, and so I think, just education is so important. And again, that's why I think this opportunity is so great. And, having a fertility cafe that allows us to have these discussions.
Absolutely. Yep.
Yeah.
Absolutely. Well, thank you so much for joining me. I really appreciate it.
You're so welcome anytime.
Absolutely. So if someone is interested, or if they're curious, or if they need some help and they just like, oh, maybe I should call her, where should they reach you?
So, our website is rbaivf.com. If you want to call to schedule an appointment with me, you can call 470-552-2624, or again, just visit our website, and there is information out there for how to schedule a consultation with any one of our reproductive endocrinologists.
Awesome. Well, thank you so much, Dr. Bessie. Appreciate it.
Thank you so much, Eloise. I appreciate the opportunity.